VA doesn't have cameras. Bummer. That's all right. All right. Well, let's get started, shall we? So, welcome to Base Camp 2020. We're going to talk about ECGs today. I have met a lot of you. I'm Eric Rudolfker. I am the Chief Resident for Quality and Safety over at the VA. I'll be here the whole year. Look forward to working with you guys throughout the year. ECGs is the topic I love. Applying to cardiology this summer. So, and I know for some it can be quite polarizing, but that's all right. We'll get through this together. Before we get started, just to give a little context, it's hard to know what's going on in the world when you're on wards. So on this day in 1984, Prince, of course, released Purple Rain. And then the news today, COVID is spreading, if you haven't heard. Today it was announced that the Segway will be retired, no longer made. So all of the mock ops will have to figure out something else to roll around on. And tomorrow Congress will vote on Washington, D.C. becoming the 51st state. So exciting things happening in the world. Things we're going to go over today. All right, we're going to reinforce the systemic approach to ECG interpretation. We'll go over some can't miss ECGs, and then we'll get some practice in too. And bonus points if you can throw into the chat the name of the person pictured in the background here who is hooking himself up to the first ECG machine in 1901. You'll get some sort of prize. The other thing I want to say before we get started is that for some of you, you may feel like a lot of this is review. And then for others, this may be like, whoa, this is a crazy learning curve. And either way, that's okay. There's something to be taken away from here, but don't feel like, oh my God, I'm so behind if this is hard for you. We'll all get there, and just use this as one of the things to focus on with your wards teams as you go through. All right, VA A team nailed it as Eindhoven. VA team D said some German dude, which I believe is still correct. But yes, this is Eindhoven in 1901. All right, some practical pearls of ECG interpretation. Just going to throw these out there. Always try and find an old ECG first. Acute versus chronic changes can drastically alter the management of things, so know what you're starting with before you interpret something new. It's usually not an emergency, so take your time, go through your systematic approach to doing this. And I say unless it's an emergency, because what the patient looks like, what their vitals are, is always first. Then if those are stable, you have a little bit of time to look at the ECG, think through it, make a decision. There's no right order or way to do this. You just have to be systematic about it. So I'm going to go through my way of doing it, but you'll develop your own habits. And then mostly ignore the ECG's machines interpretation. Sometimes that can kind of cloud how we actually do this. So this is my approach. Rate, rhythm, axis, intervals, amplitudes or hypertrophy, and ischemia. We'll spend 15 or 20 minutes going through each of these as a review, and then we'll just get into some practice. Everyone will get a turn to, or everyone should get a turn to do some interpretation. So I'm just going to go down the participant list and go through the interns that are logged on. For those that are in groups, I know there are a couple groups. You guys we'll just kind of go through the line. Just let me know how many people you have there. So rate. For rate, I usually will count big boxes to get a rough idea of what the rate is. One large box, if the QRSs are one large box apart, that's a rate of about 300 to 1, and then 150 for 2 boxes, 100 for 3 boxes, etc. Alternatively, you can count all of the QRSs on one page. The sheet is 10 seconds long, and then multiply that by 6 for beats per minute. although my multiplication tables aren't that great. So I tend to use the box method. Normal varies, but is 60 to 100. One kind of pearl and tip right off the bat is that if you have a static heart rate of 140 to 150, think of atrial flutter. That would be a 2-to-1 conduction because an atrial rate is about 280 to 300. For rhythm, there are several frameworks that you can use to identify a rhythm. This is kind of a nice one to start out with: regular, regularly irregular, or irregularly irregular. But a lot of things fall into the first and third. I tend to go more of like a flow chart algorithm where I say, okay, is it fast or is it normal or slow? Is it narrow? Is it wide? And then just know what kind of all the various rhythms are. And then I see a lot of the EP folks kind of doing this, looking at the P waves and say, what's the atrium doing? Looking at the QRSs and saying, what is the QRS doing? And figuring out the rhythm from there. So important to know what makes a normal sinus rhythm. There are 3 important things here. 1 is that each P wave is conducted. 2, that each QRS has a P wave associated with it. And then 3, that the P wave comes from the SA node. And for this to happen, you want to look for it to be positive and lead 2. And this will make a little bit more sense when we talk about axis here. But you have to know where the SA node is. So when we get into step 3 of axis, if you have the SA node up here, look at the leads that are looking directly at that SA node. So look at AVL, 1, 2, AVF. I always picture a camera looking out up this way at those things. So if the SA node is up here anatomically and lead 2 is looking right at it, you'd expect lead 2 to be positive. So for a normal QRS axis, you would want 1, 2, AVF, and AVL to be positive. 3 is usually isoelectric if it's positive. So things that are isoelectric, meaning equal positive and negative, are going to be 90 degrees away from here. Step 4 is intervals. So the PR interval is a little bit boring. It can be long in a first degree AV block, which is kind of meaningless. It can be short, NWPW, and then it can also be elevated or depressed in pericarditis, is something to remember. The QRS is a little bit more interesting. Normal is 120 milliseconds, which is 3 small boxes. If it's wide, we want to figure out relatively quickly why it's wide. So these are some things that can cause a wide QRS. And then really important that if it's fast and it's wide, that we immediately assume that this is a wide complex tachycardia and check, is the patient stable? Do we need to act on this quickly? The QT interval is normally about 450 to 460 milliseconds. Should be roughly half of the R interval, or the RR interval, or less. And we do correct it for the heart rate because a slower heart rate will equal a longer QT interval. This is the formula to do it, although the machine will do it for you. This is a patient I had just a few months back that had the longest QT interval I've ever seen. This is in the 600s somewhere. And this is important because this is that patient about 30 minutes later who is in torsades, is this rhythm. It was important not to identify all of these things that can prolong the QTC interval. These are meds we use all the time. So this person had electrolyte abnormalities. She was on an SSRI and a TCA. She had gotten an antipsychotic for her nausea. So she had all of these, and she went into this rhythm. All right, amplitude and enlargement, starting with the atria. So right atrial enlargement, or P pulmonale, will have a very peaked P wave in 2 or V1 and V2, one's the leads that generally point to the right atrium. And this is caused by anything that can enlarge the right atrium, like any lung disease, tricuspid valve disease, etc. Left atrial enlargement is also called P mitrale, and it'll have that bifid P wave where it's kind of humped here in lead 2, and it'll be longer. In V1, you'll also see it be biphasic, and that's caused by, here's a little bit of a better view of it since it's small. You see it's biphasic here in V1, and in 2, you can see it's kind of humped. And this is anything that'll cause left-sided disease, so mitral valve, heart failure, LVH, etc. For ventricular enlargement, RVH is actually really interesting. So these precordial leads, V1, it should be negative because most of the vector of forces should be going towards the LV. You should be negative and get more positive as you get closer to V6, which is on the lateral side of the LV. So in this case, you see a really tall R wave in V1 and actually a negative or an S wave in V5, V6. So it's opposite of what it should be. So you can actually see this in situs inversus if the LV is actually on the right side of the body, or if the leads have been reversed. And then less commonly, the things that actually cause RVH, like pulmonary hypertension, PE, chronic lung disease, etc. For LVH, the biggest clue is that your QRSs are going to be overlapping. But technically, the voltage criteria is if you have an S in V1 and an R in V5 or V6 that's greater than 35, that meets voltage criteria for LVH. And similarly, hypertension or hypertrophic cardiomyopathy, aortic valve disease can also cause that. So low voltage is an interesting one. We see it a lot. It's usually not that meaningful, but like here's one example, a 73-year-old African-American man who's admitted with a new diagnosis of heart failure. So what might come to mind in here? Throw it in the chat if you have any ideas. Something that might be an odd cause of heart. Yeah, so Anita got it, amyloid, yeah. So you can see amyloid or other infiltrative cardiomyopathies like giant cell can cause low voltage. And then how about this cause of low voltage? So here's a 38-year-old woman with metastatic sarcoma presenting with hypotension and dyspnea. And the voltage is kind of low throughout, and there are some odd abnormalities here. The hint is that Amelia mentioned this yesterday. So what is going on here? Throw that in the chat also. Or just unmute and say it. Tamponade, CICU, of course, crushed it. Yeah, so you have this electrical alterans pattern where you're kind of switching axis beat to beat. And then last step is ischemia. So there are 4 main signs of ischemia that I look for: the STs, the T, Q, and the R wave progression. So let's go through these. ST depressions, we'll start there, can be upsloping, and these can be a normal finding with like exercise or tachycardia. So I'm usually not too concerned. And so the slope of the ST depression kind of follows the smiley face here. A downsloping ST depression is a little bit more concerning and has a worse prognosis. So that's a little bit concerning. And then a flat ST depression could kind of be either. So I'm not too thrilled about seeing a flat ST depression also.
Should I keep my...
As far as elevations go, obviously we're most concerned about STEMI, which means that you have ST elevations in at least 2 contiguous leads, meaning of the same vascular territory. And just note that for V1 and V2, we have a little bit of a higher threshold to actually call things ST elevations. And that change, the technical cutoff changes between men. It's a little higher if you're young. It's a little bit lower for women. Unfortunately, there are a lot more things that cause ST elevations than STEMI. So here's just a list of things that can cause ST elevations, ranging from kind of concerning to more benign stuff down here. And so we don't have time to go through all of these, but take a look at this list and make a mental note if you're not familiar with any of these things. One general thing that you can do is that kind of separates the concerning etiologies of ST elevations from the less concerning etiologies, is looking at the J point, which is here where the ST segment starts to go up. If that J point right there is elevated, that's usually a more benign cause. I say usually because there are cases of STEMI where the ST segment does look like that smiley face that I put for the depressions. So don't automatically rule it out, but it's more likely to be one of these benign things. So don't forget our vascular territory. So here's a depiction up here of your coronary anatomy. I'm trying to move my participant screen, but it's stuck. Okay. So you see the RCA that kind of wraps around the back, and that brings up our inferior territory here. All the way to the right, you see these territories, 1, AVL, V5, and V6. And these are the lateral territories that correspond with the circumflex. And then here you have your anterior or LAD territories. Where's the posterior territory? Where are we going to look for posterior changes? Where is the posterior on the ECG? What leads are we looking for? Posterior leads. Okay, Mark, what are the posterior leads? Oh, like actually putting leads on the back of the chest. Yep, we can do that. But what are the reciprocal leads to those that we're going to look for here? Yeah, you want to look for reciprocal changes, and what leads are we looking at for those? So you can look here at these posterior vascular distributions. Here's the PDA. That in this depiction, it's coming off of the RCA. Yeah, so Efrat says the anterior leads. Yeah, so V1, V2, V3. So you want to look at what leads are looking at this, and that's V1 and V2, but it's the back of the heart, so you would expect opposite changes here. Great. And just note that sometimes this PDA will actually come off of the circumflex and wrap around. The other thing to mention is that ST depressions don't localize, only elevations and Q. If you see ST depressions, it doesn't necessarily mean that you're having an end STEMI in the RCA. It could be anywhere. T waves can range from non-specific, anywhere from normal to ischemia, so they can be tricky. Things that I am concerned about is if they're really deep and inverted, or in 2 or more contiguous leads. That's where I'm looking at, is it LV strain pattern? Is this a cerebral T wave? You can get T wave inversions with a definitely logic injury. If they're hyperacute or peaked, that's what I'm thinking. Is this hyperkalemia or an early STEMI equivalent? And then change is key, especially like with this LV strain pattern. If it's like that for months because of uncontrolled hypertension, that's one thing. But if someone had a normal ECG and then they're coming in with chest pain and you see those depressions or those inverted T waves, that's when you want to be concerned. Or pseudo-normalization. Yeah. I'm not sure I know what pseudo-normalization is, so throw that into the chat if you have other things to add there, Team D. Thanks for bringing that up. So Q waves are by definition an initial downward deflection before in R wave. And pathologic ones are wide and deep. So they can be normal to have a small one. You'll see it a lot in lead 3. And then note that these do localize to vascular territory and that they're a late finding after an MI. So you'll see them 24 to 48 hours after a completed MI. And then lastly, R-wave progression. So this is where you want to look at the R-wave to go from negative in V1, that should be positive by lead V4. And so if it's not turning positive by V4, that means that there's scar or injury, something that's preventing the normal repolarization throughout the precordium. TNV says if abnormal baseline, but changes, it can look normal. Changes from that because sometimes make it look normal, but really not. Yes, okay. Exactly. Any change of T waves, you should look into that. Thanks for bringing that up. So how do I write this in the chart? Here's just an example of something that I would write. Just a brief line on any, you don't have to go through every single thing that you're looking at, but kind of hit each of those steps in the order that you're reviewing it and mention any abnormalities. All right, let's take a mental break real quick, and I'll just highlight one of my favorite hikes, Herman Gulch. This is from last summer. And so how we'll do this with actually going through is I'll bring up the participants list and then just go down the list. I'll give about 10 seconds for everyone to think and then ask the some of the interns to kind of think out loud so that we can go through these. And there will be kind of some teaching points mixed in. All right, let's get started. First one is, what is the rhythm? So let's start with the ACE crew, if you can unmute and walk us through what you're thinking here.
Are we unmuted?
We are unmuted.
I think I'm seeing P waves, but the R waves don't seem to follow the P waves. So I think this is complete heart block.
All right, so with complete heart block, you're looking at AV dissociation. So you want P waves and QRSs that are completely dissociated. Here, you look at a P wave right here, and we see a QRS right after it. So maybe they're associated, or maybe they just happen to fall there. So you want to look at others. And then here you see another P wave and the QRS after it. So there may be an association there, but you do see that this PR is certainly longer than this one. And so it's correct to see that the P waves and the QRSs don't look like they're matching up well and say this might be a heart block. But if you follow them out, this actually looks like a Wenckebach or a second degree type 1 heart block here. So you have a normal PR, longer, and then there's actually probably a dropped beat here. You have a short PR, longer PR, and then probably another dropped beat that's buried in here. Great. Who else are there other interns on the ACE? There's at least one other intern on the ACE team. So let's get the next ACE person to go over this one here.
Sorry, we're having a hard time seeing it a little bit. But
Oh.
It doesn't look like there's any P waves. Is that correct? It's kind of small.
yeah.
Yeah. I don't see any P waves either.
So leads me to believe AFib.
Yeah. And how would you describe this rhythm in general terms? Like, what would this sound like?
Irregular.
Yeah, it just looks very irregular. So looking at that regularity is really important. And this is indeed AFib. So just a quick note on when you see something like in this first example, this is regularly irregular. And that's often called grouped beating. And so it's usually going to be a second degree AV block if you see that, or bigeminy or trigeminy, which is where every second or third beat is a PVC or an APC. And then for irregular, when you see that pattern, the first thing to think of is AFib. The second thing to think of is AFib, and then AFib, and then a couple other things like multifocal atrial tachycardia, which is just where you have ectopic atrial foci from various parts. So you'll have multiple types of P waves. And then wandering atrial pacemaker is very similar to MAT, except that it's just not fast. So it'll be in kind of a normal-ish rate. And then the last thing to mention is atrial flutter, which is often irregular, but you can have variable block. So if it's conducting in a 2-to-1 pattern, the rate will be around 140, 150. If it's 3-to-1, it'll be around like 90 to 100. But if it's alternating between 2-to-1 and 3-to-1 continuously, it can look irregular. And for these irregular rhythms, just note patients go into these all the time, especially hospitalized sick people. And it's usually not an emergency. People in AFib with RVR, are rarely going to die from that. And so this for me, when I was an intern, I kind of freaked out the first few times I saw these, and I was ready to call the cardiologist and cardiovert people. Just know it's usually not an emergency. You can kind of sit and think through your principles. What's going on with the patient? How do I treat AFib? Just a quick review on your AV blocks. So with second degree Mobitz type 1, also known as Wenckebach, your PRs gradually lengths and gets longer, and then you drop a QRS. And that usually happens at the AV node. The lower down ones are a little bit more concerning, and that's your type 2, where your PR is fixed, but you randomly drop QRSs, and then type 3, where you have dissociation. All right, Ace, thank you for your service. Let's move on to Alex. So take a second here, Alex, and think out loud a little bit with what's going on with this rhythm.
Okay. So looking at, obviously the most interesting thing on the EKG is in V1. Kind of looks like a sawtooth pattern. I would be inclined to kind of attribute that to a flutter, but it looks like it goes back to normalizing afterwards. Other than that, the rate is pretty fast. It's also irregular. So no, it's not fast. Anyways, it's irregular. There's some axis deviation. What? Left axis deviation? Something like that. Trying to see if there's P waves. I don't see any like real P waves in leads 1, 2, or 3. And then there's kind of that sawtooth in V1, but otherwise, yeah, no major P waves there. And then I also see some ST depression in V4 and possibly also in V3. So as far as the rhythm goes, I'd say AFib, a flutter, something like that.
Great. Yeah, I think your hunch is correct. I just want to correct one thing in that the axis here, lead 2 and lead 3 are both positive, and AVF, they're the most positive leads, and they're right in the middle of the normal axis quadrant. So I would call this one a normal axis.
Normal axis, okay.
And then, so here's lead 2. This is your rhythm strip, and you do see some of this kind of sawtooth pattern. So A flutter, typically it's going to have a fast upstroke and then a slow downstroke. And so we do actually see this throughout. Here's some bits of it here, bits of it here, but it's great you recognize this as irregular, and so your mind goes to fib here. Although with some of these other features, like an atrial rate of 300, you're actually thinking that this is atrial flutter with variable block. The other thing you can sometimes have is what they call coarse AFib, which is AFib just where the P waves are a little bit more prominent. Although I would say this is organized enough to think that this is probably atrial flutter.
Okay.
All right, let's move on to the next one. Alex, you said you're with Kathleen? All right, so it says what's the rate and rhythm? The rate, I'll just tell you, it looks pretty regular here, so let's just focus, and is about 75. So let's just focus on the rhythm.
So the rhythm, it looks regular to me. It looks like we might have some axis deviation because 3 and AVF, I don't know about AVF, but 3 looks like it's down going to me.
Yeah, it's kind of a borderline axis, right? So your tallest QRSs are 1 and AVL. So it might be approaching that left axis deviation.
And it looks like we have like P wave inversions.
Yeah, so what's this all about?
So that's when we have like a left atrium dilation.
Yeah, so with a left atrial dilation, you might see some like a wide end or a bifid P wave in lead 2, but the direction, the axis of the P wave should be consistent. So the axis of the P wave is actually telling you where the atrial impulse is coming from. So remember, lead 2 looks right at the SA node. So this should be positive if this P wave is coming from the SA node. So what rhythm might this be that is causing this P wave to come from not the SA node? Anyone can chime in.
AV node.
Yeah, well, yeah, sorry.
Yeah, like a junctional rhythm or something along those lines.
Yeah, so that's definitely the right kind of thinking. Like, where else in the heart could this be coming from? A junctional rhythm or a rhythm that is coming from the AV node or from the junction will actually not look like it has any P wave activity. So remember, this P wave conducts through the AV node and then depolarizes the ventricles, which creates the QRS. So a negative P wave here would just mean that this atrial impulse is coming from a random spot in the atrium. So you would just call this an ectopic atrial rhythm or an atrial tachycardia, although this isn't really a tachycardia. So you might call this a wandering atrial pacemaker or just an ectopic atrial rhythm. All right, good. That was a tough one. And just so you know, these are supposed to be hard. I went through these with the other chiefs yesterday, and there was one that the three of us couldn't agree on just in the few days since I put this together and went through it yesterday.
And I'll chime in, Eric, that I've been in that situation before, 3 a.m. with an attending cardiologist and saying, is this fib? Is it flutter? And it's always ended the same way. They say, it doesn't really matter.
Yeah.
So if you're getting that close and you've got it narrowed down and you've got your hemodynamics, stable, it becomes a little bit academic. So I think you guys are doing great.
Definitely. The important thing is to realize that is not a normal P wave. So, all right, Amanda, you are up next. Take a few seconds and then let's just focus on axis here. We kind of talked about it before, but where is the axis?
So I would say that the axis is normal because, well, lead 2 actually looks a little bit isoelectric to me. But 3 and AVF are clearly positive. So it's close to normal.
Close to normal, yeah. And this is, you look at like 1 is down and AVL is down, right? So we're kind of at the bottom part of the axis here. And then with 3 being positive and AVR being positive, I think we're kind of creeping over to the right axis here. So this is probably a right axis deviation. And then bonus points if you recognize the conduction abnormality here. If you look at the precordial leads like V1, V2, V5, V6.
It kind of looks like a right bundle branch
Yeah,
block.
exactly. Yeah, so this is a right bundle branch block. You have a wide QRS, kind of, you don't have maybe the classic bunny ears here in V1, but you have a wide upright QRS in V1 and V2. And I have to move the chat to see my own slide here. Yeah, so you have this right axis deviation, which can be caused really by anything that causes RVH, or can be a PE, acute RV failure, just having a right bundle from longstanding lung disease. All right, great job. Let's go to Amy to do the same thing for this ECG. Amy, are you with us or just thinking? All right, Amy took a bathroom break. Let's go on to Arman. No?
Eric in
Looks
the
like Armand's typing it.
Oh,
Armand's
chat. You can't see the chat here. Oh, it says left axis, no mics. Okay. Yeah, so this is a left axis deviation, exactly. And this, is caused by anything, kind of the same things that can cause atrial enlargements and LVH, like hypertension is probably the biggest one to think about here. All right, thanks. All right, Carly, let's, oh, Carly Little, is that, sorry, I don't know all the interns' names yet. Carly Little, are you one of our interns?
I'm not.
Okay, great. Your name didn't sound too familiar. Okay, let's go on to some of the names don't necessarily match who you are. Let's go on to Dan. Is that a Dan? Is that an intern Dan or an upper level Dan?
Could be happy attending Dan.
It could. Oh, there's also Daniel.
It might be me.
All right. Here, let's go to the DH MICU because I know there's some interns there. So,
and Eric, as you're going through, I see Erica Begler's on and CJ Mowry. I see CJ. I'm assuming it's Mowry. Bye, fam. We got a couple out there for you.
Oh, great. All right. Well, let's go to the DH MICU. We can come back. So let's see what's going on with this guy that's showing up for a knee replacement. And just kind of go through your whole interpretation here. No mic. Oh no. That's all right. Everyone's going to think about it, and you guys type. Someone type in a brief interpretation. Heart rate around 100, left axis deviation, regular rhythm, great. And you recognize the big conduction abnormality of a left bundle branch block. And you want to look at an old ECG, perfect. So you have this wide QRS that follows a somewhat normal precordial pattern, although very deeply negative QRSs throughout. And you see some bunny ears here in one, and AVL. So perfect, great. Uh-oh, if it is a new left bundle branch. Yeah, somewhat. So he is presumably, doesn't have any concerning cardiac symptoms. Sometimes you can see left bundle as a new conduction abnormality with an MI. Left bundle branch block in someone with chest pain is no longer considered a STEMI equivalent. So we're not rushing these people to the cath lab. But kind of the old teaching was that you want to treat left bundle branch block as a STEMI equivalent. Now we have such better diagnostics, biomarkers that we don't do that anymore. All right, great. I see Ellie, if you don't mind taking this one here. So this is a 55-year-old guy with COPD coming in with cough. And let's go through the interpretation here.
Hey, okay. I'm so sorry. I've been working on an admission. Okay, so let's see. His rate. Sorry, I'm probably just gonna beef this. Okay, so.
Right, we're all kind of thinking out loud here.
Yeah.
So no pressure.
Okay, so each box is the pattern rate goes 500, 250.
Yeah, so first you want to pick a QRS that kind of lines up close to a big box. So we'll say like here.
Yeah, that's the one.
The first box, if it's one box away, it's going to be a rate of 300.
300.
Next one will be 150, and then the third is 100. So
okay,
say it's close to 100.
Okay. And then looking for P waves.
Yeah, and I didn't give you a rhythm strip here, so it can be a little bit hard, but we can say that these are what the P waves look like, and they look somewhat normal. There's actually a first degree P block here.
Okay. Is this looking over at B2, is that QRS wide?
Yeah, this is a wide QRS. So just going through all the systems, you mentioned the rate, you mentioned the P waves being upright here, and it's regular, so it's a normal sinus rhythm. The axis here is kind of a borderline left axis. We're kind of isoelectric in 2, and we're down in 3, and then 1 and AVL are up. So we're kind of pointing towards the left axis.
Okay.
And looking at your intervals, your QRS you mentioned is wide over here. The direction is a little bit odd. And so this direction of having a wide QRS in V1 and V2 with this kind of pattern that you see here, and then being down in V5 and V6, do you recognize what type of pattern that is as far as a conduction abnormality?
Is this Wolf Parkinson White?
It's not, although this can look actually similar to a delta wave, but you see a clear Q here, and then your QRS. That's a good thought, and then hint that may come up in a future ECG in this talk. But this is a right bundle branch block.
Okay.
You see, you almost can imagine some like an RSR prime here in V1, like a bunny ears pattern with a wide QRS and.
And is that always in V1?
You'll see that RSR prime in V1 and V2, and then in S wave in V5 and V6, which meaning you have a down. So that's a right bundle branch block pattern.
Okay.
And that's contrasted to this before. We saw this left bundle branch block pattern, which is kind of the opposite. You have deep, wide, downward deflection.
Okay.
All right. Great. Thanks for thinking through that in front of all of us. All right. I see Erica, I recognize, is next.
Yeah, hi.
Okay, if you don't mind talking through what's going through your head for this one. This is a 33-year-old that came into the ER, or actually, let's say she's in your clinic as an ER follow-up for syncope.
I'm looking at rate. So.
And whoever's in the same.
Okay, sorry, we're having some feedback problems.
So
it looks like rate's probably 50 to 60.
Okay.
So maybe
great.
A little slow.
Yeah. Can be normal for a 33-year-old.
Yeah. Just looking at P waves. It looks like there's P waves with. Yep. Well, am I actually seeing the P waves? Okay, yeah, right there. Yeah, so with each QRS. For access, looks like it's normal. And wide QRS, they're a little abnormal. Shaped like in leads 2, 3. Oh, is this Wolf Parkinson White?
Yeah, so what is this extra kind of wave here called? That's
Sorry, I'm not hearing.
Yeah, so this is, so you're seeing delta waves here. And the other is a very short PR interval. So the PR just goes right into the QRS with this upsloping delta wave. And so this is, there's an accessory pathway, and you can have really fast tachyarrhythmias with a reentry here. And so that's why, you know, if you see this, you want to make sure that they see an electrophysiologist to see if they need an intervention. Great. So you also hear this referred to as pre-excitation, and that's because the ventricles are getting depolarized, aka excited, prior to going through the AV node, which is the normal pathway. All right, great. We have a couple more and 5 minutes left, so perfect. Oh, well, I see a question in the chat, but I can't hear. Are there any things that cause short PR that isn't WPW? I always think once I note short PR. Yeah, I can't really think of anything that would cause a short PR other than an accessory pathway, because that's that same thing. The myocardium, the ventricles are being depolarized prior to that pause that naturally happens at the AV node. So I don't know.
I would say just your AVRTs probably, Eric, when you think about common causes. There's other, we all know Wolff Parkinson's, right? There's other rare syndromic things, but I think it's just your AVRTs and junctional rhythms.
Yeah, so the AVRT, so AVRT by definition has an accessory pathway. So it's a very similar mechanism there. For AV-NRT, it's really hard to see any P wave, so it's hard to calculate a PR interval. With AV-NRT, you're often seeing a retrograde P wave, which means you're just getting a micro reentrant tachycardia around the AV node, and you're seeing kind of the opposite of depolarizations. So it's hard to really calculate a PR interval there. We actually look more at the RP interval, and we'll classify SVTs into a short PR or a long PR. That's kind of its own talk. That's, I think, a little bit beyond the scope of what we'll go into today. But if you ask your cardiology fellows on the CCU, they would love to talk to you about short and long RP tachycardias. All right, who do we got next? We got a lot of people logged on as iPhone. I'm not sure if any of those are interns that want to take a shot at this one.
Eric, I can go. This is Oliver.
Hey, Oliver. All right, great.
Here, I'm gonna mute so that we don't have feedback.
Well, don't mute yourself because we won't be able to hear you. But if you turn your sound,
there we go. Sorry.
That should be better. Yeah.
So I think notably there's ST depression in V2, V3, V4, as well as ST elevation in like V5, V6, a little bit in lead 2 and AVF as well.
Mm-hmm.
So given the story, I think I'd be worried about like a posterior inferior lateral MI.
Yeah. So what makes you think posterior? We kind of talked about this earlier.
So we have like the depressions for the ST segments in V2, V3, V4. I think about those as like reciprocal change.
Yep.
That, like our would-be posterior leads.
Yeah. And so an important thing is to not miss that this could be actually a STEMI in the posterior leads. Sometimes you might see these ST depressions and say, oh, this is consistent with an N STEMI. But don't forget that this can be a STEMI in that posterior distribution. So what you can do is a posterior ECG, which for this patient they did. They did a V7, V8, V9, and you can see where those are placed there. And you see actually some ST elevation now in V8, in V7, 8, 9, which would be consistent with a posterior MI. So here's the original one again, and Sneha just said, turn this baby upside down, y'all. So if we actually do that and flip it, you can see what V1, V2, and V3 will actually look like, and you can see those clear kind of tombstone-y STEMI equivalents that we want, and then deep T-wave depressions. All right. One more minute. This is kind of a fun one, and then we'll end here. Mallory or Mark, if one of you, I see you here, so if one of you would jump on and take this one.
We'll take it. Dom has the answer.
All right.
So one thing that kind of stands out to me is, I think it's Osborne waves right before the QR, or right after the QRS, just kind of indicative of hypothermia.
Yeah, so there are a few ECG abnormalities that are associated with hypothermia here. You mentioned this, which is called an Osborne wave, which is a little J-point elevation with a kind of a doodad right before it. That's an Osborne wave. I see probably two other things that stand out to me as being consistent with hypothermia here.
Super bradycardic.
Yeah, slow heart rate. Great. And there's one more.
The T wave.
Yeah, I'm not sure of any specific T wave abnormalities. I was more actually looking at the baseline. This guy looks like he's shivering based on the kind of wavy baseline here. So that can be another clue. So these are important to recognize, especially in a hypothermic patient, because the answer for this person might not necessarily be pacemaker or a dopamine drip, but it might actually just be warming the patient up.
Okay.
It's usually obvious when you're seeing someone with a low body temp, but here are some additional signs to help with your management. All right. So we're out of time. I did just have one more that focused on Brugada syndrome, which I would encourage you all to just look up. And then some of these Wellens other T-wave abnormalities, kind of deep biphasic T waves, are something to recognize as a STEMI equivalent. And there are a few more. We'll just kind of skip through these. Here are some resources. Life in the Fast Lane is a great blog it's where I got a lot of these examples from. This is also an ECG library that has like a quiz-like feature to it where you can go through, and when I used to go through one a day with my team, and that was always fun. And then just talk to your chiefs if you're like, wow, this was really hard. I'm really struggling with this. Because we want you to all feel good about when someone throws an ECG in front of you in the middle of the night. Great. So this was great chatting. Thanks for those that contributed their minds and thought and were willing to think out loud in front of all of us today. Please reach out if you have any questions about any of these, and look forward to working with you guys in the next couple of weeks. Have a good afternoon.
Thanks, Eric.
Thanks, Eric.